without further ado, we'll go ahead and move on to our presenters. So today we have Doctors Kaitlin Fertaly and McKenzie Javorka. I'm just going to tell you a little bit about them, and I have had the privilege of uh, witnessing their presentations in person, which are amazing. So you're in for a treat today. This is great information. I'll start with Dr. Fertaly. Kaitlin is the Director of Research and Evaluation at the University of Montana's Rural Institute for Inclusive Communities. Trained as a qualitative social scientist, she holds an MA in anthropology and a PhD in geography. Her work sits at the intersection of public health, health systems, and community engaged research with an emphasis on rural contexts and populations that have been historically underserved. So we welcome you today. And then Dr. McKenzie Javorka is a researcher evaluator at the Rural Institute for Inclusive Communities at the University of Montana as well. And she completed her MA and PhD in community psychology at Michigan State University. She conducts research and evaluation from a health equity lens using community engaged, qualitative, and mixed methods approaches. Her work has spanned topics including rural health, sexual violence prevention and response, communicable disease, and maternal and child health. So we welcome you two here today, and we'll let you take it. And if I didn't let you all know, sign in with that link in the chat there, and welcome to those of you who have joined us.
Thanks for such a warm introduction, Stacy. I will start by trying to recreate my screen share, and hopefully it will go as planned. Right. Hopefully you can all see our title slide. As Stacy mentioned, we're going to be talking today about PrEP. We conducted a needs assessment to help understand awareness and access to HIV pre-exposure prophylactics in Montana. And before we kind of jump in further, I just want to give a quick positionality statement around this work. So McKenzie and I come to this work as researchers and evaluators. I am not a clinician. I am also not someone who can speak from lived experiences of the perspectives represented in this assessment. My role was to listen carefully, to synthesize what participants shared, and to help translate those findings into practical recommendations for improving HIV prevention in Montana. So throughout this presentation, we'll try to be clear about what the data show, where the interpretation is limited, and where the findings point to opportunities for action. McKenzie, do you want to add anything else about your perspective or who you are?
I think you covered it really well, Kaitlin. Thank you for that.
All right. Thank you. All right, so I have to give a quick disclaimer, which is that this needs assessment was supported by the CDC and the Montana Department for Public Health and Human Services. However, the contents of this presentation, the findings, the interpretations are the opinions of McKenzie and I, and do not necessarily represent the views of our sponsors. And we also have no financial conflicts of interest. So I want to get started by giving a little background on PrEP and how we came to this needs assessment and why we focus specifically on PrEP. So just a little level setting around PrEP, because we were just at the Syndemic Symposium. Can you give a quick show of hands if you were also at the Syndemic Symposium last week in Helena, just so I know who is gonna might be hearing this for the second time. Okay, I got a couple of folks. So I want to give a quick shout out to Christopher Zivalich at the National Coalition for STD Directors for the content on this slide. He shared a brief overview of PrEP and what it is and who it's for. And I thought it was really well done and would make for great context for our work. So very briefly, PrEP is HIV prevention. It is over 99% effective at preventing HIV transmission via sexual activities. And PrEP can benefit anyone who is at risk for acquiring HIV. And I think that this point is really something that I took away from his overview slide because so much of what we've seen in PrEP research and in PrEP needs assessments and even ours is focused around MSM, which may kind of leave some communities underrepresented in that work. And PrEP is effective preventative care. It's been given an A rating by the U.S. Preventative Services Task Force and includes STI screenings. And that's really important for insurance purposes and reimbursement purposes, which is a little bit less of the focus of our presentation today. And finally, PrEP can be a part of primary care. It is an effective prevention strategy, and it can be integrated well with other primary care needs. And that's another key point that I think is relevant to connect to the findings of our needs assessment. So to give you a little bit of background on what we've been up to and why we did this PrEP-focused needs assessment in 2025, we have to go back to 2022. So in 2022, we worked with DPHHS to conduct a statewide HIV and hepatitis C needs assessment. And we wanted to examine key gaps, barriers, and facilitators across the HIV and hepatitis C care continuums. And that assessment combined interviews with people living with HIV or who had hepatitis C. We surveyed healthcare providers to gain an understanding of their perspectives, and we interviewed local health department staff, and we took all of that to create a kind of comprehensive picture of what the needs are, what the needs were related to prevention and treatment. So what we learned about prevention and specifically about PrEP in that 2022 needs assessment was really striking. There were significant barriers to accessing PrEP reported across all three data sources. Providers, health department staff, and patients lacked knowledge about and comfort with PrEP. Findings from our survey of healthcare providers were particularly striking. Nearly 1/3 of healthcare providers, and these were MDs, DOs, nurse practitioners, registered nurses. Nearly 1/3 reported not routinely offering information about PrEP to their patients. Providers were the least comfortable discussing PrEP compared with any other HIV or sexual health related topic we asked them about, such as injection drug use, sexual history, or safe sex practices. And 1/3 said they would not feel comfortable prescribing PrEP if a patient met criteria for its use. In addition to the information from our 2022 needs assessment, national epidemiological data have indicated that rates of PrEP use are notably low in Montana. So for example, according to data available from AIDSview, which is a great data dashboard for folks who are unfamiliar with that, and McKenzie, maybe you could type the name of that in the chat. It's AIDSVU in Montana. So according to their data set, in Montana, only 73 people per 100,000 were using PrEP as of 2024. And just for a quick note on the data nerds out there, the AIDSVU data set is a little bit different from what the CDC was using. So if you've been kind of tracking PrEP uptake through the CDC, they've pulled that data source for now and they're working on it, but AIDSVU uses a different data set. And another way of looking at it is to use the PrEP to need ratio, which is the number of people taking PrEP for every one new HIV diagnosis. And when we look at it this way, Montana fares somewhat better, with about 25 people using PrEP for every one new HIV diagnosis. And for this metric, higher numbers are better, indicating that PrEP coverage relative to the need is a little bit higher. The fact that we do better on this metric is not surprising, given that Montana is a low prevalence and low incidence state for HIV cases. However, these data together suggest that we have room to grow in terms of PrEP uptake as a primary HIV prevention strategy. So based on the information from this 2022 needs assessment, as well as this public health data, our partners at DPHHS wanted to understand more about the barriers to PrEP for Montanans from the perspective of those individuals themselves, which led us to the current needs assessment. In this needs assessment, our goals were to describe the awareness and use of PrEP among Montanans at risk for HIV. We wanted to identify barriers to starting and continuing PrEP. We wanted to explore the factors that affect access to PrEP. And we wanted to hear from the participants themselves, their suggestions and ideas for how to inform future PrEP programs and policies. So in sum, we wanted to understand factors along the PrEP care continuum, from awareness and understanding of one's own risk to accessing care, initiating PrEP use, and adhering to it. So how did we do that? Our assessment had 2 phases. Our first phase was an online survey where we surveyed Montanans with an elevated risk for HIV exposure. We recruited them through an online ad campaign and through community organizations. Ultimately, we received 94 valid responses, and we accepted those responses between December 1st, 2024 and January 31st, 2025. The second phase of the needs assessment was to conduct interviews. We interviewed people who were eligible for or currently taking PrEP. Those folks were recruited in person at service programs or community organizations. We put up posters and flyers. We added this to social media and recruited through word of mouth. We were able to conduct 22 interviews between June and October 2025. Next, I'm going to describe our survey and interview samples, like who we talked to. And I know there's a lot of numbers on this slide, so I'll just highlight a couple of similarities and differences here. In terms of sex, the survey and interview samples were similar in terms of being predominantly male. The survey sample was somewhat more racially and ethnically diverse and younger, which makes sense, kind of given our recruitment strategy and the statewide reach. Interview participants, on the other hand, included more sexual minority individuals and older adults. The survey sample also had more representation from people living in micropolitan and rural areas compared to interview participants. And if folks aren't familiar with the word micropolitan, that kind of refers to the areas outside of larger cities, kind of a different word for suburban. Great. We also kind of look at our participants when we get to the findings. We talk about them in terms of risk domains, or these kind of categories of behavior that place participants at an elevated risk for HIV. And something that I took away from the Syndemic Symposium last week is that we talk a lot about risk in this in our presentation. And one of the other speakers, kind of also shared about how that word can also contribute to stigma. So when I talk about risk, I also just want to remind folks that sometimes it just looks like people having fun, right? And so when we talk about these risk categories, these are ways that people live their lives, and I don't want to associate that necessarily with negative connotations. So our survey respondents included more people who use drugs. The survey and interview samples were similar in terms of the proportion of men who have sex with men. And although we did not ask interview participants about their justice involvement, this was fairly common as a risk factor among survey respondents. And finally, many survey respondents, about 40%, had more than one HIV risk factor, whereas only one of our interview participants was in both the MSM and people who inject drugs categories. Another way to think about who participated in our needs assessment is to sort them by PrEP use. And this, we've kind of described it as the proportion of participants who were currently or had formerly taken PrEP. And an important thing to note as we look at this survey data is that our survey intentionally recruited people with PrEP experience. Therefore, the rates of PrEP use among our survey sample should not be seen as representative of PrEP use in Montana. Among survey respondents, we see that nearly 70% reported currently or formerly using PrEP. And that's definitely not generalizable to Montana populations. About 1/3 of interview participants were currently using PrEP. So with that background and setup, I am going to hand it over to my colleague McKenzie, who will walk you through the findings. McKenzie, if I don't know when to change the slide, just tell me.
Perfect. Thanks, Kaitlin. Awesome. So yeah, now that we know a little bit about kind of what we did and who our study participants were, let's get into some of those main findings. All right, next. Perfect. So I'll present these key findings kind of generally in order of the PrEP care continuum, moving from awareness of PrEP and perceptions of HIV risk to factors associated with PrEP use, barriers to use, and reasons for adhering to or discontinuing PrEP. And then finally, I'll wrap up with some recommendations from participants and then pass it back to Kaitlin to talk about what this might mean for practice and public health. Perfect, thanks. So starting with awareness, overall awareness of PrEP was high among our survey respondents. More than 9 in 10 said that they had heard of PrEP, and nearly 3/4 were also aware of the newer injectable form of PrEP as opposed to the daily pill. One thing that we also saw is that social media and healthcare providers were the most common sources of information about PrEP among survey respondents. But interestingly, those participants who had learned about PrEP from their friends or their family were the most likely to currently be taking it. So a little bit of an interesting fact there. On the side of our interview participants, somewhat fewer of the interview participants, 16 of the 22 were aware of PrEP. So 6 had either never heard of it or maybe had seen an ad for it on TV but didn't really know what it was or what it was for. And none of our MSM interviewees were unaware of PrEP. So all the MSM folks that we talked to were aware of PrEP. Next slide. So despite this overall kind of strong awareness of PrEP, we found that participants pretty consistently underestimated their personal risk for HIV when we compared that to their behavioral risk factors that they reported. So in both surveys and interviews, individuals who were at risk for HIV due to drug use were more likely to underestimate their risk than other risk groups. So for example, a participant who saw herself as low risk said, "Right now, since I'm with a steady partner, I would say my risk level is low since he says he does not have HIV and I only share needles with my partner." So for us in the kind of public health sphere, that might indicate, some behaviors that are associated with HIV risk, but this participant saw herself as at low risk. And perceptions of risk were also related to participants' willingness to initiate PrEP. So although most of our survey respondents were willing to learn about PrEP or talk about it with a provider, only 36% said that they anticipated seeking a prescription soon for it. And interviews kind of suggested that this disinterest in starting PrEP was often linked to folks thinking that they were just at low risk for contracting HIV and so didn't think PrEP was necessarily relevant for them. Next slide. So then moving on to some of the factors associated with PrEP use, we kind of looked at this by different subgroups and examined demographic factors and risk domains, as well as some general indicators of healthcare access and engagement. So what you can see on the slide here is that respondents with insurance and/or an established primary care provider had much higher rates of PrEP use than those without. So specifically, 48% of those with insurance were currently taking PrEP compared to only 6% of those without insurance. And 47% of those with a primary care provider were taking PrEP compared to only 24% of those without a primary care provider. An important reminder here is that These are only descriptive differences. We didn't do tests of statistical significance for this, but they are suggestive of a pattern. A few other findings related to kind of PrEP use and demographics were that survey respondents who were white and gay or queer had the highest rates of currently taking PrEP, whereas only about a third of Black and multiracial respondents reported being on PrEP, as well as only about 26% of bisexual and 32% of straight respondents. And then another kind of looking at risk factors, most respondents who were at risk due to either justice involvement, MSM activities, or drug use were currently taking PrEP, compared to only 8% of respondents with non-MSM sexual risk factors. And among the interview participants, the 7 participants who were taking PrEP were all MSM. All right, next slide, please. Awesome. So moving into barriers to PrEP use, we kind of divided these into 3 themes. So PrEP-related stigma, discomfort with providers, or providers' discomfort with PrEP sometimes, and then healthcare and PrEP access barriers. So I'll talk about each of these themes in turn. So starting with PrEP-related stigma, survey responses showed that this was a concern for many respondents, especially in relation to kind of privacy related to PrEP. So many respondents said that they would be uncomfortable with their family, friends, or sexual or romantic partners knowing that they were taking PrEP. And 35% of former PrEP users said that one reason they had stopped taking it was because they were worried that other people would find out they were taking PrEP. And these kind of stigma and privacy related concerns were higher among those who were justice involved, queer and bisexual respondents, as well as those using drugs, which kind of suggests that this privacy concern and PrEP related stigma might be intersecting with other forms of stigma related to drug use, sexuality, or incarceration. But then kind of in contrast to that, among our interview participants, they generally described seeing PrEP as responsible and a health promoting behavior. A few did describe fears of being outed by taking PrEP, or some lingering associations of PrEP with kind of promiscuity, particularly among the gay community. So for example, one participant said, "For a long time, I got my PrEP prescription filled at a pharmacy where I didn't fill anything else because I had worked with people at my primary pharmacy. So for probably 2 years, I filled it elsewhere just because it was my own fear." So moving on to discomfort with providers, many of our survey respondents reported discomfort with talking about topics related to PrEP with healthcare providers. So specifically, 40% said that they felt uncomfortable talking to their provider about drug use, and 38% felt uncomfortable talking about their sexual behaviors. And this discomfort with providers was highest among folks who had never taken PrEP, those who had only non-MSM sexual risks for HIV, and Black and Hispanic or Latino participants. And among interview participants, some did describe having experienced stigma or kind of uninformed care from providers and needing to self-advocate in order to receive PrEP. So for example, one participant said, "I've had to be proactive about volunteering information about my sexual health to healthcare providers that I've had. I've definitely experienced discomfort from more than a couple healthcare providers in this state, even just talking about sexual health." On the other hand, we also had interview participants who gave examples of really positive, LGBTQ-friendly, culturally competent healthcare providers who had facilitated open discussion of HIV risks and PrEP. So it really just kind of depended. Participants also noted that just lack of provider knowledge about PrEP, or kind of providers not initiating the discussion about PrEP, were barriers to starting on PrEP. So one participant said, "I guess it was interesting to sort of have to explain to her a little bit about PrEP and about why I wanted it. It struck me as kind of weird being she knew about it, but it was like, okay, so why do you need this? And it just seemed like she was generally uninformed about the drug itself. Next slide, thanks. And then finally, moving into our third kind of barrier category of healthcare access barriers. Many survey respondents reported having concerns about finances or logistics related to accessing PrEP. So these concerns included things like the cost of care, the need for frequent clinic visits, and having to travel in order to find a provider that they trusted and felt comfortable with. Only 15% of the survey respondents reported that they had no concerns about accessing PrEP. And these barriers to access were more frequently reported by rural residents, people who had never used PrEP before, and Black and Hispanic or Latino respondents. And then similarly in interviews, participants talked a lot about cost and insurance coverage as potential barriers to PrEP uptake. Although interestingly, those participants who were already on PrEP they didn't report facing any barriers relating to cost or coverage. So this is a little bit more of kind of the hypothetical barriers that folks were thinking about when they were asked about what might prevent them from taking PrEP. One participant said, I guess my primary barrier to using it thus far has been cost, because I don't believe I would be able to afford it. And in fact, I know I couldn't. It's not in my budget currently, but it would be something I'd be looking into in the future. So then we also looked at some reasons for either adhering to or discontinuing PrEP. And among survey respondents, just as a reminder, 28% said that they had taken PrEP in the past, but were no longer taking it. So we asked these respondents, what were your reasons for discontinuing PrEP? And what they said is half of them reported discontinuing PrEP due to side effects. 46% had doubts about its effectiveness, and 35% had concerns that someone would find out they were taking PrEP, as I mentioned earlier. In contrast with this, none of the interview participants that we talked to who had taken PrEP had ever completely discontinued using it, but a few did report needing to change kind of brand names or dosing in order to deal with some of the negative side effects. On the side of reasons for maintaining PrEP, interview participants really emphasized that PrEP provided peace of mind for them. It reduced their anxiety around sexual activity. For example, a participant shared, I think it's primarily just a safety thing. My partner is HIV positive. Even though he's undetectable, I feel like it's an ease of mind or peace of mind kind of thing for me. And then some other participants said that they stayed on PrEP because they continued to engage in high-risk behaviors, and they didn't anticipate that their risk level was going to change. Participants also said that it was easy for them to maintain PrEP once taking the daily pill had just become part of their routine. Next slide, please. So then our final set of findings involved kind of recommendations from participants about how information about PrEP could be made more accessible and how PrEP itself could be easier to access. So about half of survey respondents preferred to learn about PrEP from their regular medical providers, which really highlights the role of, traditional clinical settings for HIV prevention information and counseling. But in addition to that, trusted local resources like public health departments and community-based organizations that participants already went to were also preferred sources of PrEP information. Really, the kind of key theme here, especially among interview participants, is that they just wanted information about PrEP to be more readily available at their doctor's offices, in community settings. They just wanted to walk in and see PrEP kind of normalized and see information about it. And then looking at kind of accessing PrEP and options for that, online PrEP services did appear to be a compelling option for many people in our study. So most survey respondents said that they had either already used online PrEP services, which was about 26%, or said that they would use those services, which was 55%. And particularly compelling, 83% of survey respondents who had never used PrEP said that they would be open to using online PrEP services, indicating that that might be a good avenue for a lot of folks who haven't used PrEP before. And then interview participants suggested just making PrEP more accessible by offering it in community-based settings, especially at, syringe service programs or other programs for people who use drugs. So basically, in sum, participants wanted information and PrEP itself to meet them where they're at, whether that's at their regular doctor's office or in a community setting that they already frequent. Next slide. Oh, and I will turn it back over to Kaitlin to kind of close us out with some implications.
Great. Thank you, McKenzie. All right, okay. So drawing on the findings that McKenzie shared, we wanted to share with you all a few potential implications for taking that information and moving it into practice. So first, outreach and messaging about PrEP should focus on educating priority populations about the benefits of PrEP and addressing misconceptions about eligibility. And this is particularly needed for people who use drugs, heterosexual individuals with high-risk sexual contact, and people living outside of urban areas. And this messaging could emphasize PrEP as a prevention method for all at-risk populations and not just for men who have sex with men, as well as explicitly framing PrEP as prevention to clear up confusion about its purpose. Our second implication is to provide targeted education to increase awareness of personal risk. Study participants consistently perceived their risk for HIV as lower than their risk behaviors would suggest. So to address misconceptions about HIV risk, health departments could engage in targeted educational campaigns to align individuals' perceptions with their actual behaviors. This education could be tailored to address the specific needs and concerns of populations like people who inject drugs, who might not recognize the full extent of their HIV risk. Healthcare providers, particularly primary care providers and family physicians, are well positioned to have honest, non-judgmental conversations with patients to help them accurately assess their risk based on a holistic view of the patient's risk factors. Our third implication or recommendation is to increase access to low barrier PrEP services. Given the barriers associated with traditional healthcare access, accessing PrEP could be improved through promoting options like online or mail order PrEP services, offering PrEP in community-based settings, and increasing mobile health clinics. These alternative delivery methods may also help to address barriers related to privacy concerns and discomfort talking about HIV risk with one's regular provider. Fourth, our findings emphasize the need to improve providers' knowledge of HIV and PrEP, including PrEP eligibility criteria, insurance coverage options, and the broad spectrum of behaviors that might warrant its usage. Ideally, providers would be trained to have non-stigmatizing discussions regarding sexual health and drug use, as well as to implement universal HIV screening protocols as recommended by the CDC. This not only normalizes the conversation about HIV risk, but also creates regular opportunities for PrEP education and counseling. And lastly, our findings suggest a need to combat PrEP-related stigma. And to help address this, health departments could develop or support campaigns that reframe PrEP use as a positive and responsible health behavior. Increasing awareness of confidential and discreet methods of PrEP delivery and consultation, again referring to those online services, may help to mitigate privacy concerns and social judgment. That's it for our recommendations, but before I open it up for questions, I want to take just a few minutes to talk about some limitations of our studies to help contextualize our findings. So first, this study was not intended to represent or generalize to all Montanans. Our recruitment strategies focus most heavily on recruiting LGBTQ plus individuals and people who use injection drugs. Respondents with higher HIV risk and those who have used or are currently using PrEP are intentionally overrepresented in our findings compared to the general Montana population. Our findings should also be understood as descriptive patterns within the sample, not as population estimates or causal effects. Although we engaged in a variety of recruitment strategies, we were also not able to get to all corners of the state, either in person or other ways. And so we were unable to really promote the study in the more rural and frontier parts of the state. So our sample again skews towards the more urban areas of our state and the more western region. So this would mean that individuals at risk for HIV who live in rural areas may be underrepresented. And they may also face unique barriers to accessing PrEP that are not captured by this needs assessment. And finally, our study intentionally focused on the population of potential PrEP users in order to understand current low rates of PrEP uptake in Montana. We did not include the perspectives of healthcare providers regarding their comfort with and knowledge about prescribing PrEP. And as we noted, we have some information about this captured in the 2022 HIV and Hep C needs assessment, but we feel that a potential area for future exploration would be to better understand the barriers that providers are facing in talking about PrEP or in not talking about PrEP with their patients. And that information can help flesh out a more well-rounded story about PrEP in Montana. So with that, I'm going to turn it over to questions, but there is a lawnmower buzzing around my office right now, so I might go on mute and let McKenzie take the first couple.
The lawnmower is also outside of my office, but I think it's in Kaitlin's general vicinity right now.
I thought it was a marching band. Wasn't sure. Um, thank you. Thank you, McKenzie and Kaitlin. It was more informative the second time, so thank you. I appreciated it. And there weren't very many people here who had already heard it. So yeah, any questions from the group? I have some questions for the group that I think will help get you talking. And we also have the evaluation link in the chat. If you could click on that and give us your feedback, and so you can get your continuing education as well. But what questions do you all have? You can put them in the chat or you can come off mute. Well, if anybody has any, feel free to continue thinking about them and putting them in the chat. Until then, I have a question for all of you. I'm wondering if you can just put a yes, no in the chat if you are currently educating people about PrEP, like maybe when you're doing screening or testing or seeing them in clinic or your health department. Yes or no in the chat. And this is just to get kind of an idea of where people are at with their needs for information. Okay.
While
Nice.
they're doing that, may I ask a quick question?
Yeah.
So from a clinician's perspective, what is the barrier to that contributes discomfort to discuss PrEP? Is it I don't know anything about this drug, I'm uncomfortable because I haven't prescribed it, or what is it? That is there anything specific that's actually they felt that led to the discomfort?
Yeah, so is the question kind of on the provider side? What are some of the
Yeah.
barriers? Um, I think the thing that we heard, and again, this is from not from the perspective of providers, right? But what we heard from the people that we talked to is that a lot of times providers just didn't bring it up, or didn't bring up topics related to sexual health in general. And so because that is a stigmatized topic or can be a stigmatized topic, a lot of people didn't feel comfortable kind of volunteering the information or bringing it up themselves. I think the other piece was just that, as we kind of heard from some of the, particularly the interview participants who were on PrEP, a lot of times they had to kind of do some education for their provider about what it is and why they wanted to be on it. Not always. There were a couple of folks who their provider was the one who said, "Hey, I'm looking at your risk factors, or I'm looking at, you just told me about this. Have you thought about PrEP? Let's talk about that." But so it was kind of, depended on the person. But I think just because sexual health and drug use can be uncomfortable to talk about with providers, that if providers weren't the ones bringing it up, um, or if they were bringing it up, particularly, I think a lot of folks shared having experienced judgment around drug use in healthcare settings, that was a major kind of contributor to that discomfort.
Thank you for that. I think that, I trained in a large academic medical center. I trained in Albuquerque. So, and I think, and what I've noticed is that many, ID physicians in general are much more comfortable about talking about sexual health just because we got thrown into that because of HIV and all the STIs, for that matter. I mean, but I also recall like through my medical training in like going through medical school, yeah, we're taught that we're supposed to talk about sexual health or get a good sexual history, but that is such a voodoo thing. I just remember my attending just kind of skirt around, oh yeah, you should ask them, but then didn't really teach us how to approach it. And I think that probably still the case in many places. And I could see, we had two training program here in Billings, and they're kind of very similar. I mean, they don't really ask very good questions because it's a voodoo topic. And now, granted, part of it is lack of education. Part of it is afraid of cultural, right? I mean, it's just it's not something you talk about. It kind of that Midwestern mentality, And then there is also that, and I think is maybe that fear of don't ask me personal questions, or I'll kind of, and I say that is because we also have this, many hospitals are now using these patient experience surveys, and there's a fear of coming across wrong, inappropriate, and then you get deep, right? There's a lot of that, and I think that just kind of works against the goal of like trying to bring this up. And now the reason I kind of bring that up is that last week I was on a service, and actually it was a Riverstone patient, and who is clearly has a practice has risky sexual behaviors. Interestingly, she's married. She and husband is in a completely open relationship, and she was very open about it. But when I asked her about it, it's like, well, okay, I'm fine. I mean, I'm not judging you on that, and I made it very clear. Look, I'm not here to make that judgment. But on the other hand, is the fact that she was very. This is going to kind of your about the perception of risk. She was fine with the fact that, oh yeah, I sleep with multiple men, have unprotected sex, and she didn't see that as a problem. But and she would be the perfect person I would target for having this discussion about HIV PrEP and doxy-PEP.
Yeah.
Fortunately, no one has. And that was where I was like, kind of like, where I was like, has anybody talked to you about it? No. I was like, come on. And she was very open about it. It wasn't, I didn't have to coax her. Her husband was in the room and actually told me everything. But no one has talked to her about that, which is actually, I think that's really kind of and whether, and that's why I wanted to see, is that also as our clinicians, now you're hearing about all these weird, unusual, hey, maybe let me rephrase that, non-traditional sexual practices. That's probably a better term. Is that discomfort with that that's really preventing them from having a discussion, because I mean it's like kind of that ignorance is bliss. I just don't want to know about it. Right. So and I just want is that have you encountered anyone giving that much of detail about, yeah, I just really don't want to talk because I just don't want to go down that road.
Yeah, absolutely. And I do think that, we had several participants who we talked to in our interviews who were in open relationships or engaged in polyamory or things like that. And so I do think that, unintentionally, if a provider feels uncomfortable talking about some of those practices, it can definitely then, contribute to that kind of discomfort. So yeah, that certainly came up in our study.
Which leads my question is, was there any suggestion on how to overcome that anxiety or reluctance?
That's a good question. I think that the big thing that I heard is just to talk about it. Like, and for it, I'm pretty sure we had at least one participant say, just be honest. Like if you're a little uncomfortable, just name it as a provider. But that kind of normalizes like, hey, this might be uncomfortable to talk about, but I want to make sure to ask you about these things. And then, you can kind of both be in that maybe slightly uncomfortable states together, but you're still having the conversation, identifying the potential risks, and then providing information. So yeah, great questions.
And just final question and a comment, just to add. I mean, and it didn't surprise me to hear about how the response you received from the LGBTQ community, because I think many of them, I mean, yes, we that the stigma is actually what of all HIV, these STI, Mpox have really promoted that. Okay, we need to do better, and I think, and there's a lot of messaging on social media for that. There are gay physicians who are out there advocating for PrEP, and many of them get big lots of followers. I don't know if that is a case on for the heterosexual group. I think that, whether that's because and this is a more now trying to avoid political, but it is kind of that when we're talking about HIV, the first thing people think about isn't the straight heterosexual person. The first thing they think about is the gay man. And then the same thing with Mpox. When you talk about Mpox, we don't think about that anyone could get it. We think about the gay man who goes cruising. And that's the problem. And I don't know there's any messaging out there too to kind of really to kind of really encourage, like, hey, if you're having sex, you're at risk for getting an STI. But I think that in their mentality, and I think that whether that contributes to their assessment for risk or not, it feels that way because they just don't see it, because they're not hearing it. So I don't know if there's any measures that will kind of approach, any focus group that's really addressing that population to say you are still at risk, other than usual GC chlamydia, which, yeah, you can treat it, but anyway, yeah.
Yeah. Kaitlin, I saw you come off mute. Did you have something you wanted to add to that?
Oh, and just to reiterate, that was one of the things that struck me too about the findings. We definitely went in with a focus on LGBTQ populations. I think we were looking at some of the epi data and we're like, how can we boost this? But I think what surprised me, I always learn things, is how aware the LGBTQ community is about PrEP, and how it's those kind of other groups who have risk factors that have missed the messaging. And so that may be the next step in sort of bringing those other groups to the same level of awareness as the LGBTQ populations. I have a very anecdotal story that's not part of the needs assessment, but a friend of mine who's a medical provider, but a white woman my age, went to a doctor to get on PrEP for good reasons, and they told her no. Why? And she actually faced a lot of barriers as a provider herself in getting access to that. And so it's just a reminder that kind of we associate PrEP with a specific population, but in doing that, we might be missing some other folks who could benefit from it.
Thanks for sharing that, Kaitlin. Um, so uh, you said something, Dr. Koo, about like how do we get clinicians? Like, is there a way? And McKenzie said just talking about it, and I think practicing, normalizing the conversation, and maybe it's awkward at first, maybe it feels uncomfortable, and clinicians just have to know that it starts with them if their patient isn't going to be like, Caitlin's friend or the people going in and saying, "Oh, I can tell you all about it." But there are people who have language that then the clinician can say, "I heard you say this. Tell me more about that. I'm not familiar with that language." Like it sounds like you know something I don't know and I'd love to learn, like getting that going. But clinicians don't have a lot of time, and I think it's hard to incorporate something new. Um, so hopefully that can happen. I'm wondering, it looked like most people are educating about PrEP in their clinics or health departments. I'd like to know if you are referring for PrEP, like if you feel like you have the tools you need to refer for PrEP, yes or no? Okay, good. And my next question, unsure. Thanks, Cynthia. Thanks for being honest about that. And then my next one would be, do you have a provider that you have a relationship with that is prescribing it? Like a provider who is prescribing it in your community. Okay. Yeah, so this is a problem, right? Because we can tell people what it is and we can tell them why it might be helpful for them as prevention. But if we don't know that somebody is actually prescribing it, now there are some online resources, and we can share some of those with you in our post-session email that you can always give to people. You can print off something to give to the people that you're talking with so you can get them a little bit further towards that. And I think in that conversation with the PrEP would be the doxypep also, like combining those two. Sometimes people don't see their risk for HIV. Anybody who has an STI is at risk for HIV. So it doesn't matter who they are, and they are eligible for PrEP. I think the CDC is who recommends offer this, educate it. But sometimes talking to them about the doxypep for syphilis, they've heard a little bit more about syphilis recently, maybe even somebody they know where HIV might feel like a little further away from some people, but we know the risk is there. So I think just normalizing it, getting comfortable talking about it yourselves. So, all right, well, we're out of time. Oh, go ahead,
Sorry,
Ken.
I just really quick wanted to add something. It wasn't super common, but we did have one person in our sample who had exclusively used online PrEP services. I believe that he used Mister, MISTR. I know Q Care is another one, and it was really great for him. You can complete all of your consultations with providers via telehealth, and then get the PrEP in the mail. And so he never had to go. I don't remember if he had to go in and get labs drawn. I think they actually sent him a kit to do the lab or the blood draw himself. And so it was completely, remote virtual. And so for folks who do have the tech access for that, I think that can be a great option if there's not a prescribing provider locally.
Yeah, I've seen people with their kits, they still have to go to a lab to get the blood drawn. But if the lab, like I've seen a lot of Quest, and we don't have Quest in our community, so they're trying to get other people to draw the blood in this kit to send off to Quest, which most labs will not do. to send to another lab, but if they can find a place to get their blood drawn with that kit. Yeah.
So one barrier I see with those, I think they're great they are great services to expand access, but I think aren't these, you kind of have to have insurance for these, which,
Or
right?
self-pay.
Yeah, and that's the barrier, is that if it turns out that they don't have insurance and none of them pay, then we're kind of back to square one,
Yeah.
which is, yeah. So I think that, whether, and there'll be another totally long discussion, but I see that probably more as a barrier why your numbers didn't surprise me, how many are on prep, had been on prep and off is because you, this is one of those things that's not always covered by, well, not covered by Medicaid. And unless you have good insurance, it's not good. You have to pay out of pocket. So,
Yeah, and it has to be, insurance has to cover it if it's prescribed. I mean, that is the rule, but you need some strategy behind that sometimes, like your
yeah.
pharmacist needs good strategy. Okay, sorry to keep you a minute past, everybody. We put the sign-in link. I think I put the sign-in link. Was that what I did? Oh, I meant to put the evaluation link. Sorry, Desiree. I'm so sorry. So please give us your feedback. We'll see you again on June 2nd. We have Dr. Amy Solomon talking to us about managing addiction in your office from withdrawal to long-term recovery. So that should be a great topic, and we look forward to seeing you then. Thanks so much.